Advanced Imaging for Detection and Differentiation of Colorectal Neoplasia, European Society of Gastrointestinal Endoscopy, ESGE Guideline Update, 2019. Introduction. Colonoscopy is the key examination technique in colorectal cancer (CRC) screening programs for detection and treatment of early precursor lesions and timely diagnosis of colorectal cancer. The quality of colonoscopy, which depends on both bowel preparation and examination technique, is the main determining factor that drives the protective effect of this invasive examination in decreasing the societal disease burden. Over the last 15 years, several new techniques to improve polyp detection and characterization have been developed and studied. For all these techniques, the possible financial burden, learning curve, and additional cost need to be balanced against the potential benefit. In general, there is a potential bias in the available literature, given that it is impossible to blind the endoscopist to the technique that is being studied. Therefore, even in the setting of a fully randomized trial, there is always a potential bias in favor of any technique that may affect the performance of the endoscopists, even subconsciously. This update of the previous published guideline aims to put into perspective the new evidence that has become available over the last 5 years and to provide statements on the possible role of advanced techniques in polyp detection or characterization in average-risk and high-risk populations. The potential role of artificial intelligence, AI, in detection and characterization of colorectal lesions, including possible hazards of its implementation, has been addressed for the first time. With regard to training in optical diagnosis of diminutive polyps, detection of colitis-associated neoplasia, and prediction of invasion with larger polyps, Bisschops et al. Refer to the standardized ESGE training curriculum. Although this is a work in progress, the authors anticipate that the curriculum will be available in 2020 and want to include this defined standard in the guideline as a prerequisite for obtaining cognitive chromoendoscopy (CE) skills for lesion characterization and detection. Main recommendations. ESGE suggests that high-definition endoscopy and dye or virtual chromoendoscopy, as well as add-on devices, can be used in average-risk patients to increase the endoscopist's adenoma detection rate. However, their routine use must be balanced against cost and practical considerations. Weak recommendation, high-quality evidence. ESGE recommends the routine use of high-definition systems in individuals with Lynch syndrome. Strong recommendation, high-quality evidence. ESGE recommends the routine use with targeted biopsies of dye-based pancolonic chromoendoscopy or virtual chromoendoscopy for neoplasia surveillance in patients with long-standing colitis. Strong recommendation, moderate quality evidence. ESGE suggests that virtual chromoendoscopy and dye-based chromoendoscopy can be used under strictly controlled conditions for real-time optical diagnosis of diminutive colorectal polyps less than or equal to 5 millimeters, and can replace histopathological diagnosis. The optical diagnosis has to be reported using validated scales, must be adequately photo-documented, and can be performed only by experienced endoscopists who are adequately trained, as defined in the ESGE curriculum, and audited. Weak recommendation, high-quality evidence. ESGE recommends the use of high-definition white light endoscopy in combination with virtual chromoendoscopy to predict the presence and depth of any submucosal invasion in non-pedunculated colorectal polyps prior to any treatment. Strong recommendation, moderate quality evidence. ESGE recommends the use of virtual or dye-based chromoendoscopy in addition to white light endoscopy for the detection of residual neoplasia at a piecemeal polypectomy scar site. Strong recommendation, moderate quality evidence. ESGE suggests the possible incorporation of computer-aided diagnosis, detection and characterization of lesions, to colonoscopy if acceptable and reproducible accuracy for colorectal neoplasia is demonstrated in high-quality, multi-center in vivo clinical studies. Possible significant risks with implementation, specifically endoscopist de-skilling and over-reliance on artificial intelligence, unrepresentative training datasets, and hacking need to be considered. Weak recommendation, low-quality evidence.